Is it the expectation in 21st century America that I should be absolutely, positively, 100% pain-free?
Absolutely, Peter. And I just want to mention to our primary care physicians, there's so much more that you can do other than opioid medication.
I was going to go there. Why don't you start us off?
It's always said that arthritic pain gets better with rest. However, I think in this day and age, rest is not going to bed. It should be interpreted as activity modification. So for example, if you have pain only when you're running 5 miles, I tell the patient, well, would you consider using an exercise bicycle? Would you consider swimming? If your knee only hurts when you're skiing moguls, I've told some professionals, I think it's time to go down to greens and blues. And if you can do that, that's fine. That's the activity. But I think it's important to do something. But I try to emphasize you want to do the right kind of activity.
So let's call this activity modulation.
Correct. That would be a great.
It's like the old joke. Why do I come up with these old jokes today? It's the guy goes to the doc. He says, "Doc, it hurts when I do that." And the doc replies, "Stop doing that.
Yeah, right.
Do something else."
Well, this is a lifestyle disease, right? That's where it affects most people on the fringes, right? At that point, it's elective and it's advice. When it starts to affect day-to-day activities like going to your job or sleeping at night, that's when it gets more serious.
So it's not just don't ski moguls. You can't say stop sleeping.
Right. So when it affects their daily life to the point that they can't make a living, they can't take care of their family, they can't sleep at night, then it rises to the level of needing some sort of intervention.
And I would add to that as the face of arthritis gets younger, we're seeing more and more of those kinds of complaints.
Okay.
In a 75-year-old, we were more likely to be able to say, okay, well, maybe you should live with this, maybe you should modulate your activities. But if it means saying to somebody, gosh, you can't do the basic requirements of your job on a day-to-day basis, that's a significant problem where we really need to intervene.
Where do the anti-inflammatories come in here?
So I think for our primary care physicians, I would recommend they use over-the-counter medications first. So acetaminophen, ibuprofen, things like that. I've actually noticed that patients don't want to take medications anymore. There's too much in the lay press about this medicine causes liver problems, this medicine causes high blood pressure, this medicine can give you a stroke. So I've noticed a sea change in that patients are not interested in medication. So perhaps there is a role. I generally tell these weekend warriors, okay, if some of these over-the-counter tablets help you, if you've got to go out and play 18 holes of golf or you've got to run this charity 5K, take a couple of these pills that morning and take some afterwards and put ice on your knee. But most patients don't want to take this on a regular basis, and you know what? They probably shouldn't.
I've got a friend of mine who runs a restaurant, and he's behind the counter a lot. And he's got osteoarthritis. And I asked him, how do you manage this? I asked him, because I knew I was coming here today.
Yes.
He said, I take a Tylenol in the morning.
You see that?
And I get through the day. It doesn't cure my disease, but it means that I'm okay. Is that rational?
Of course, I think so.
I have bilateral osteoarthritis of the knees. I take 2 Tylenol and 1 naproxen every morning, and that's how I get through the day. But the interesting thing is, patients are reluctant to take medication, as Paul says, because there's a lot of information about prescription and over-the-counter medications that the FDA has approved. Yet they'll go to the GNC store and buy every over-the-counter supplement they can that has no literature basis in fact and has no characterization of their side effect profile, and they'll take double the strength because they think that's going to be better. So I would recommend they stick with something their doctor recommends.
I think one of the things that we can do for patients is to really empower them with some self-management options as well, and give them the permission to use that Aleve or ibuprofen in a manner that is rational and effective for them, and empowering them to have sort of a toolbox of options, whether it's a brace, whether it's exercises to maintain strength of the quadriceps and balance of the hamstrings, and all of those kinds of factors. That's, for me, the patients, I live with their osteoarthritis 15 minutes once every 3 months. They live with it 24/7. And so giving them those tools to help them on a day-to-day basis I think is where we can be most useful.